to
This
go first.
conference will now be recorded.
I'm I'm happy to start. I've got a few.
Okay, I'll make you the presenter.
All right, let me see if I can hide everyone so I can actually see my screen. Okay, do you guys see my database screen?
Yep.
Mm-hmm.
Okay, so this is a youngish patient who came in a couple months ago originally and had a white count of over 100,000, was diagnosed with, ended up diagnosed with some form of leukemia, and I don't remember, but came in with fever as well, diagnosed with pneumonia at the time. And I show this just to pay attention to the heart. His heart looks okay, at least his left ventricle, normal, if not a little on the thick side. No coronary artery calcification or anything. Then he gets better, and then he comes back uh, and has this CT that is done. And this is done, so he has relatively acute onset of dyspnea. He had recovered from his prior episode. And now you can see lungs look a lot different. He has considerable amount of septal thickening, and he still has ground glass and some confluent consolidation. But whereas before there's no discrete central lobular nodules, and this is really on a background of really severe septal thickening, a lot of peribronchial cuffing, and even maybe tiny effusions at this point. And this was, as I said, relatively rapid onset of dyspnea. And what was not originally detected at the time, though, was the explanation for this. So this was like two months after that other CT, and apparently in the interim he had gone somewhere else and had an acute myocardial infarct. And actually, we can see a fleck of calcium here. And you may have seen this on the lung windows as I was scrolling through. His RV is now dilated, which it wasn't before, and as you can notice that the inferior portion of his septum is not only thinned, it's even a little hypoenhancing there. And as you scroll further down, you can see there's a huge post-infarct VSD. So his septum has ruptured. And so now he's presenting with just florid heart failure and high output cardiac failure from this. And so, Howard, I know you've mentioned this in the past. I mean, I suspect this is all edema from just, what is it, stress failure of the capillary membrane, like the acute, basically just flooding of alveoli, presumably
Yeah,
from fluid. Yeah.
yeah, it's a
So,
bit asymmetric, but that's a thought that
yeah.
because of the sudden
And I
and
think,
severe capillary hypertension and stress failure. Yes.
yeah. So again, we show this not infrequently. Like, not everything that fills the lungs is pneumonia. And he had had pneumonia before, but there's a much better explanation. And he was not febrile at this time. And, he has gone to repair and had a patch repair of his septum, but, it was delayed a little. It wasn't recognized right off the bat. But, I think it's important to look at. And there's a lot of clues here. The fact that his ventricle is now just severely dilated. His right ventricle suggests there's maybe some either over circulation or strain, and in this case, over circulation, and then that big old
Wow.
hole in his septum that's acquired.
One wonders what made him susceptible to a substantial infarct.
Yeah, that's a good question. And I don't know if you know, because he definitely had pneumonia before. He was undergoing treatment for his lymphoma. I'm not sure. Um, Now, I've seen one other case comparable to this 15 years ago. We do have a hyperbaric chamber here at Duke, and which is why we saw this case. But this is a patient who has esophageal cancer, and the esophageal cancer is actually, or it's actually gastric cancer, and that's unrelated to what happened here. But he was undergoing a CT, and it was intended to be an iodinated contrast enhanced exam. Apparently, at an outside institution or facility, when they injected him, he became unresponsive on the table. You can see a little bit of air in his veins, and then a lot of air in his SVC, and then even more air in his pulmonary artery. Now, fortunately, by the time they actually called a code, or by the time that anyone had responded, he was lucid again, had no residual deficits from this, but was sent here for hyperbaric oxygen and discharged a couple days later. But like I said, this is the second largest amount of air I've ever seen in the pulmonary artery, and presumably the word was that the injector had just not been hooked up properly, and instead of contrast, he just got a bolus full of air,
Gosh.
and ended up with a little bit of, I guess, what was just either aspiration or asymmetric edema. But they never even got another radiograph after this, and he was completely fine when he left. So, um,
It's it's cool how well you
yeah,
can see the pulmonic valve leaflets.
yeah, right there.
Yeah.
So I don't know if anybody,
You
and of
see,
course there's didn't even show the RV as well.
do you see air in any of the pulmonary arteries in the lungs?
You do, going out into the, as where you would expect, like in the right middle lobe anteriorly. I know I've shown a case of
Yeah.
well, not microscopic, macroscopic, but on a smaller scale, um, pulmonary air, when you can see two parallel tubes. So let's see here.
Yes.
I think this may be a little bit. Now we'll go back to the sharper lung kernel. So he's got a little bit of bronchial wall thickening, I think, here. So this is air in the pulmonary artery adjacent to that, right
Yeah.
there and right there.
Right. Right.
And you would
Yeah.
expect it to go anteriorly. And in fact, actually, it looks like, Howard, there's even a little in some lower lobe pulmonary arteries. That's good. Yeah, good question. So
So he became sort of unresponsive for just a moment and then recovered.
a brief period
That's
of
correct.
time, right?
Yeah.
I don't know if we're
Yeah.
talking seconds or minutes, but by the
Okay.
time that the
Yeah.
code team was there, there was, he was lucid again.
Yeah. I wonder if it's, some kind of airlock phenomenon. So if you're trying to
Yeah,
pump blood through your lungs and you've got so much air, then the forward motion of blood through your lungs is not going to be great. And therefore, the blood returning to your left heart is going to be less. And it's like,
yeah,
yeah, kind of basically an air block phenomenon.
right.
I've seen a case, something like that. I don't think the patient became unresponsive, but I've seen a case like that in the course of neurosurgery, and a whole bunch of air got into the pulmonary artery via a vein, of course, and they saw the air coming in on the TEE in surgery and
Hmm.
just described kind of a fairly abrupt cessation of forward blood flow because so much air prevented the blood from going forward. Yeah,
Yeah,
must be really
I,
scary,
I,
especially when you see
I
it
don't
in
know.
surgery.
Yeah, and they, like I said, they never got imaging once he was here, and you can even see some in superficial veins as well. But
Mm,
I don't know how quickly this resorbs because, of course, we see
yeah,
small amounts of air in central veins all the
yeah,
time. So I don't know if he needed the hyperbaric chamber, but he got it and did
okay.
better. All right, Jeff. This one, this is a a baby who has a lot of congenital issues, and not even going to go into the cardiac stuff because I think the most interesting thing is the airway here, and I'm curious what you guys think. So intubated, no TE fistula. There is an esophagus there, and you will see here. So you've got what looks like the carina here branching left, going to left upper lobe, going to right upper lobe, which may be a little occluded. But then if you follow this, there's an airway that continues down, and then you essentially have still trachea and then a separate branching.
Oh, okay.
And yeah, this one, if I show you coronal minips here, or I don't even have to show you a minute. It's almost like it's a double trachea or double carina here. It's not because this is like, I think it's just like bilateral replaced upper lobe bronchi and then some remnant of a what's left of the trachea to get to the lower lobe bronchi. But it's like splayed, like Gumby almost here.
It's like a case of I have a case of a sling with a bridging bronchus that sort of has a double carina. It's interesting. It's two
Yeah.
left SVC too. I saw going down. What's the
Yeah.
morphology of the lungs? Are they morphologically different, or is there isomerism of the
You know,
lungs?
no, it didn't look like it because there's a minor fissure on the right, kind
Hmm.
of. Some of their right upper lobe looks to be collapsed. Let's see,
Hmm.
I think sagittal might
Or just
help
look
with
at the
that.
relation of the artery.
Yeah. If they're eparterial or
Right.
hyparterial. Let's
Maybe
see.
hard to tell. He's so little.
Yeah, I somebody showed this to me and I was just kind of mesmerized by it. And I
As you
don't
say.
even know. Yeah, their pulmonary artery anatomy is a little wonky as well.
Yeah, it's hyparterial on the
So,
left. The right's tougher to
yeah,
tell.
yeah, I think it's probably, I was thinking it was that it wasn't symmetric branching. Like it still looked like you still had, it looked like a right middle lobe,
Uh-huh.
Soup's egg, and then basilar segments. So it really looked like they had a normal or relatively normal right and left lungs with just that crazy bronch. So, yeah. So I think this is cases from a couple years ago, and I just stumbled upon it, and they had actually written this up as like a double carina or whatnot. But I think it's more just bilateral replaced upper lobe bronchi off the trachea, and then this little
Yeah,
bridging trachea here. But it's just a crazy morphology.
very.
Yeah, that's really cool.
All right, and then I will show. Let's see which one I want to show. I'll show one more here. Um, so this guy, this was done when? This was in 2019. So this guy was 20 at the time. This is a coronary CT, and he's a 20-year-old who has advanced coronary artery calcification for 20 years old. And I think it's probably related to his underlying syndrome. That's not why I show this. I do think it ties in. At the time, his lungs don't look, you know, they don't look completely normal, but they don't look terrible. Maybe you could say there's just a trace of reticulation, a hint of reticulation peripherally. I saw him last month because he is doing worse from a respiratory standpoint. And now you'll see he's developing a little bit of apical fibrous scar, whatnot, but a lot of reticulation and
Hmm.
even a little bit more focal fibrosis here in the left lower lobe. And so this is clearly progressed. And as you look at the bases, he's got a lot of reticulation. And symptomatically, he's worse too. His PFTs have declined. He still has some functioning, like he can go up a couple flights of stairs, but his lungs, if you were just looking at this, you might think he's 80 years old based on his lungs and his coronary calcium, and he's developing early fibrosis. And genetically, that's in fact what he has. He has dyskeratosis congenita and is now developing fibrosis related to that. So the reason they were doing this CT is he'd had a bone marrow transplant because dyskeratosis congenita is a telomere maintenance mutation, and so cell lineages with high turnover, just like TERT mutations and other familial fibrosis. You see anemia, other failure of marrow lines. You can see fibrosis. He's got a lot of skin issues, like all of his fingernails have fallen off. He's going blind, but has a reasonable quality of life otherwise. But I've shown a case in the past. I think you guys probably have seen the rare case too of advanced fibrosis in these patients. But he's now 24, and his lungs are starting to deteriorate. And interestingly, it's an X-linked recessive gene with variable penetrance because apparently there's a brother that also has the mutation but has zero symptoms, which I don't understand. But yeah, so it's one of those just rare syndromes, but occasionally creeps up when you're trying to evaluate for interstitial lung disease.
Quite a few of the nodules are right on the pleural surfaces, lymphatic pattern like.
Yeah,
Needed to see
you know,
under the microscope what's actually sitting on those pleural surfaces.
yeah.
Just a curiosity.
No, I agree. And I know one of the cases I have in an adult who had advanced fibrosis, it was unclassifiable. It
Right.
looks more like reticulation now and a little bit of traction. And I don't, yeah, you're right. I don't know, but he's going to end up with just horrible lung. So, all right,
Wow.
Jeff, I'll stop there.
All right. Thanks, Travis. All righty. Who'd like to go? Peter, Howard?
I've got two.
All right.
Okay, let me just see. I have to change a system preference, so why don't you go ahead to someone else and come back to me?
All right. Peter, do you have cases?
No, I don't have any cases, Jeff.
All right. I'll show some then. Uh, let's see. All right. You see my screen?
Yes.
Yeah.
Okay. So this patient was a trauma, and you can see there's a clavicle fracture and there's some contusion up here. But the reason I'm showing this is we've shown a couple of cases of what's been described as the karst mountain appearance of a gradient, a gravitational gradient within lobular filling. And we've seen cases of edema, and I've shown a few examples, re-expansion edema, other causes of edema. But this is the first time I've seen this appearance here in a trauma. And so I think what we can probably say, and of course this is contusion, so this is blood, is that it probably is a good reflection of intralobular liquid of some sort, whether it's edema or blood. But this is the first time I've ever seen it. And I don't know if any of you have ever come across it before, because usually trauma, I mean, I would think it wouldn't have time to settle out or sort of more diffuse involvement, but just a really nice example of that intralobular gradient, the so-called karst mountain. With Howard, I think had shown that case report where it was re-expansion edema. We've seen that, and then we've seen other cases of it. I showed several, but I added this to my differential for the karst mountain as blood in the lobules. But I think it can be useful for distinguishing at least edema and hemorrhage from things like other causes of ground glass opacity, because I've not seen it with other infections or other things, acute lung injury.
Yeah.
Okay, go ahead.
Sorry, no, that's interesting. I just caught the last part of what you said. That's a nice example.
Yeah. So this is a young person who has cystic fibrosis, and you can see there's a bronchiectasis, and there's these bilateral upper lobe masses, and here they are on the laterals. Um, and there's a stent in the SVC from a previous stenosis from a port. And this is not a complex case. This is a good case for some of the trainees out there. But you can see there's bronchiectasis, but in this cystic bronchiectasis are these layering masses, and these are been there for some time. I'm just showing the most recent scan, but these are intrabronchiolar aspergillomas in a patient with CF. It's not our typical patient. Usually we see them in emphysematous bullae or cavities from sarcoid or TB or other causes of holes in the lung, but you can see them in patients with bronchiectasis, especially if they form these larger cystic spaces. This patient does not have ABPA, which you can also encounter in cystic fibrosis. And if there's any question of if it's an aspergilloma or something else, you can always prone them or roll them to see if they layer out. But here we can see they layer in the posterior portion. But I don't recall seeing this very often with cystic fibrosis of true
No, not at all.
aspergillomas. Okay. And then the last two cases I have are both related. They have the same clinical diagnosis. So this first patient is a middle-aged patient, and let me find the most recent CT here. Yeah, so this is the oldest CT. These patients both have interstitial lung disease. When this patient presented, they presented with this lower lobe predominant classic organizing pneumonia pattern. You can see a nice atoll or reversed halo sign. Here's giant atoll here, but a very classic organizing pneumonia. And then if we look at the most recent scan, this is about a 10-year difference. You can see this has evolved into more band-like disease. It's the overall severity is milder, and this has been kind of hanging out there. There's this perilobular thickening, so there's some sequela of this organizing pneumonia pattern of lung injury. And this patient has an anti-synthetase syndrome, and the specific antibody in this one is PL7, which I believe is like the second most common one that's encountered with anti-synthetase syndrome. So it's an antibody to a specific tRNA. And then this other patient also has an anti-synthetase syndrome, but he has the anti-Jo1 antibody, which is more common. And they can sometimes have a myositis-like picture. He has the mechanic's hands and all of that. And you can see he's got a really nice basal predominant fibrotic lung disease. It's a good candidate for a fibrotic NSIP. It's more peribronchial. There's traction bronchiectasis. There's some areas of subpleural sparing. When and you sort of get a little bit of a straight edge sign on a coronal, but he's got such a low burden of disease that you don't see that. And it's probably gonna get mad at me. Let's see if this, yeah, a quasi sagittal here. You can see a little bit of a four corner sign too. You get a little bit of anterior upper lobe and a little bit of posterior lower lobe disease. So anti-synthetase syndrome often looks like other connective tissue diseases. There are different specific antibodies. Jo1 is the most common, and I believe PL7 is the second most common. And they range from organizing pneumonia to NSIP. They can present acutely with acute organizing pneumonia, and they can progress to an NSIP. And they have varying prognosis. Some of them hold pretty steady. Some of them have mild disease, such as this patient. You can see the other patient got better, but there was some residua of it. So it was nice to see those at the same time with different mutations. All right, and that is all I have this week. All right, Howard, you ready?
Yeah, I'll try again, see if it works. Okay, that's more promising. All right, do you see my database so far?
Yes.
Yep.
Good, okay. Both of these cases I came across in the post-op setting. They were both sent here to thoracic surgery department for operations from the outside. So the information I have is a little bit incomplete, but ostensibly this patient was sent with a history of Cushing syndrome, and I don't know of what duration. So we'll scroll through here, make sure I've got the right patient actually. Nope, this is different. Sorry, wrong patient. Just give me a second. No, this is the other patient with, apparently the patient was imaged at the outside because of the discovery, I think on abdominal CT, of nodular enlargement of the adrenal glands. And they went ahead and then imaged the chest as a further evaluation of that. And on this exam, the finding is not a primary lung cancer, but this right here. So that's the totality of it. There's small lymph nodes. I presume this one is not quite related to that. It's away from it. But that's pretty much it. It's kind of an oval-shaped anterior mediastinal lesion, para-aortic. Here, selected images. So this is a Gatto vibe, and we have pre and a little bit later. So it's enhancing a bit. There it is. But it's kind of a bucket lesion, needs to be taken out. And as you might expect, the preoperative diagnosis for this is a thymoma, which is quite reasonable. So again, let me look at a previous one. There it is. And this turned out to be, under the microscope, a thymic carcinoma, in particular, a squamous cell tumor. So there's no way to really separate out preoperatively thymoma from thymic carcinoma, I don't think, reliably. They both present as masses. They could be relatively small, very large. I suppose if you have a lot of invasion, you might suspect thymic carcinoma, but I don't know of a way to separate those two out except under the microscope. So, very typical findings under the microscope. Of course, it's an epithelial cell tumor. This one was positive for P63, was one of the ones it was positive for. And a couple of items about that. The mortality depends on obviously a whole bunch of things, but it can range all the way from, well, in this particular database that these guys looked at, these were the 1, 3, and 5-year survival rates for squamous cell carcinomas, or that variant of thymic carcinoma. And I think squamous cell is the most common form of epithelial thymic carcinoma. Sometimes, like other squamous cell tumors in other patients, even places like lung, sometimes some patients present with hypocalcemia because the squamous cell tumor produces PTH or PTH-like substance, but not what this patient had. So I don't know the relationship between this, if any, and the adrenal glands. This might just be sporadic, idiopathic, mild nodular enlargement of the adrenal glands, and it's kind of symmetric on both sides. The next patient is the patient that came in with a history of Cushing's. Clinically was diagnosed some time ago. And let's take a look at this interesting finding here. And the morphology of this is really interesting. Instead of being a spherical nodule, you can see this is actually tubular. And right here, it branches, which is really interesting. So that's of some relevance, you'll see in a moment. But very clearly, a more tubular branching structure. So that is the finding. And with Cushing syndrome, nowadays, very reasonable to go ahead and do a dotatate scan. So somatostatin analog for neuroendocrine cell tumors. And of course, biochemically, they found ACTH level was very high. So there it is, and very hot right there. And absolutely, this is a, sorry about this. Let me try and make it smaller. There we go. An ACTPH neuroendocrine tumor. Here you can see a nice description of the pathology of it. There are a couple of incidental tumorlets adjacent to it, pretty typical cell surface receptors like somatostatin and ACTH. And a couple of informational items. Pulmonary carcinoids may be located in the airway or not. I think we can really conclude that this one is in the airway. Maybe some of what we see on the CT is actually mucus behind the smaller carcinoid tumor itself. It's about 10% of Cushing syndrome. Other places, small cell carcinoma, carcinoids, islet cell tumor of pancreas, and thymic carcinoids. So a really typical case of ACTPH, CTH producing neuroendocrine cell tumor. I was actually surprised they measured it at 2 centimeters. Didn't look that big to me. But nice case. All right, Jeff, those are mine for this
All
week.
right, thanks, Howard. Yeah, I've seen one thymic carcinoid, and when I remember it was years ago, I remember reading about it. They can be pretty aggressive depending on their differentiation, unlike
Yeah,
pulmonary carcinoids. But that's all I
yeah. I
know
was
about it.
going to say.
Go ahead.
Well, I was just going to say the only way I know that there's a difference is if it's behaves like a malignant carcinoma that has metastasized elsewhere. You know,
Yeah,
based
yeah,
on
that's a
the
point.
based on the mediastinum itself, I would have never guessed that was a carcinoma.
Yeah, yeah, just looking at that alone. Yeah.
All right. I think that's everyone. Well, thanks for sharing your cases. I'll talk to you next
Let me
time.
see if I actually have one more. I think I might
Oh,
have one more. Let me
excellent.
see. Now that I remember, let me see if it's this one. Because I thought I showed this before, but maybe I didn't. And let me see. I'm just going to look at this.
And Jeff, I can show one more too. I'm back in the reading room, but I have it pulled up whenever Howard's done.
Oh, yeah. Okay, here it is. So I
Okay.
haven't looked at the case for a while, but let's have a look. So we have a patient that comes in that looks like that. Let me just get the timing of things. So this is, yep, okay. So radiography in February and the CT. Okay, let's have a look at this. So this patient has pleural effusion, acute chest pain, and you'll see subsequently the patient was imaged here with the CT, and you can see from these thumbnails that the acute aortic syndrome protocol was used. And I can't remember exactly, but I'm going to assume that maybe the chest pain had a back pain component, or maybe the back pain was actually dominant, and the patient was thought to have potentially acute aortic syndrome. So let me actually, just for fun, make this a little bit bigger and see if anyone can see something interesting beyond pleural fluid, maybe a little interstitial edema, but there's something else here, subtle on radiography, that,
Paravertebral.
Yeah, there's that bump just near the corona,
which side are you looking at?
right?
Yes, right here.
I saw the
Absolutely.
left first, but then yeah, then you're right, Jeff. That
And then
right is a little bit more
maybe right
focal.
there. Yeah. So here, kind of seems quite focal here, but then we have aorta, and then we have this interface that needs accounting for. So let's put up the lateral. Yes, there's interstitial edema and pleural fluid. And yeah, you're going to see. Okay, so let's go for this. Non-contrast first. Look what's happening here. Oh, not that.
Is there one disk space that's narrowed? I can't tell if
Ah,
it's
yeah.
just
You're
parallax
looking
with
right
the
over here,
others
right?
or
Yes,
yeah.
sorry. Hey, what's happening here? Let me just see what's happening here. Um, contrast. It's weird. Okay, that's better. Okay, so non-con. Scroll through there. You're looking at the aorta, and you say, "Oh, wait a minute. Maybe we should look back here." Okay, there it is. Sag. Pretty dramatic. Absolutely. So there's your disc space, paravertebral mass, acute osteomyelitis discitis, presenting undoubtedly, I would think, with substantial back pain. So not acute aortic syndrome, but acute osteomyelitis discitis is the cause of the pain, not acute aortic syndrome. Pretty dramatic.
That's
A lot
impressive.
of disease back there. Looks very nasty.
Mm.
Okay, that's my other case I was going to show.
All right, thanks. All right, and I'll give you control, Travis. All right.
All right. Do you see my database or do you see a radiograph?
Yeah.
Okay. So this patient is in their 50s and they have a known diagnosis and we're just coming in and we actually saw a non-contrast CT on this patient, but this is uh, just going to review some of their prior imaging. So her lungs look busy, and we'll get to that in a moment. She has a right aortic arch, as you can see, and it doesn't look like, well, there's no mass spec on the trachea. It doesn't look like it has an aberrant subclavian artery. Her, and I think the busyness in her lungs you can account for with her pulmonary arteries. The hyla, central pulmonary arteries look big. Her left pulmonary artery looks enlarged. And you'll see on CT that most of this is dilated tortuous peripheral pulmonary arteries. So she carries a lifelong diagnosis of uncorrected congenital heart disease. And you will see here, this is now the second adult I've seen with this diagnosis. And of course, with mirror image branching, you think about TET truncus transposition, you know, the big three T's. And in her case, she is an uncorrected truncus arteriosus, type 1. You can see there's a little bit of a main pulmonary artery there. And surprisingly, apparently is still reasonably functional in the sense that, Howard, you'll appreciate this, she can still play 9 holes of golf. And, she's, I think, not doing as well as used to be able to. You can see there's a ventricular septal defect there, which is why things are communicating. But her pulmonary hypertension is getting worse. She has a dysplastic atrial or ventriculo-arterial valve there, so the aortic valve. And I think her coronaries are just big because of the hypertrophy of her right ventricle. I don't think there's any fistula. And then you can see in her lungs, she just has classic findings of pulmonary arterial hypertension with the plexiform arteriopathies and all these dilated corkscrew networks of vessels out peripherally.
Yeah.
So it's unclear. She wasn't diagnosed until age 2, and it's unclear why there was a delay in diagnosis, but she's still reasonably functional like this.
Very
Let me
neat.
see more of the lungs
So
again.
let's see, and the reason we came across this, she actually got a non-contrast CT last week, and I'm not even exactly sure why, but just you can see those just dilated peripheral vessels. Let's see, I'll
Yeah,
move
there's
it
a
up
nice
for
one
you.
there in the left lower lobe, a nice corkscrew vessel. Some people call those
Where's my,
Sheehan vessels after the first author of a paper that in part described those tortuous corkscrew small pulmonary arteries, Sheehan.
let's see. Yeah, you've shared that paper with us in the past, right?
Yeah. Oh,
But
yeah.
yeah, you can see,
Yeah, MIPS is great.
yeah, no actual arteriovenous malformations. I mean, she's obviously got a huge cardiac shunt as it is, but these are all
Yeah,
just the dilated arterioles. So
very nice.
uncorrected
Okay.
truncus.
Very cool. All right. Well, thanks everybody, and I'll talk to you
Thanks,
next
guys.
time.
Thanks, everyone.
Bye.
Have a good week.